We are live now.
Good evening, everyone. We welcome you all to Ortho TV Online in association with Oref. To introduce today's topic and speaker, I hand over to Oref Chairman, Dr. John Mukhopadhyay.
Good evening, everybody, and welcome to this fifth in our series of 8 webinars on pelvic and acetabular fractures. We are privileged to have Professor Kong with us, who's going to talk to us about classification of acetabular fractures, and I'm going to talk about the decision-making in acetabular fractures. This webinar, as you're all aware, is brought to you by Ortho TV as well as Omnicuris. So we need to thank them for putting in all the effort so that this can be broadcast to a large number of people. So without much further ado, I would request Professor Kong to give his talk on classification of acetabular fractures. Professor Kong.
Thank you, John. Okay, this is going to be a little bit slow going because it is not an easy topic to teach and certainly not easy to remember. But we all have to have classifications, and a classification has many advantages. The first of it is, get my slide moving. Yeah. You need to understand the basis and principles why a classification was evolved and how to use it in a very practical manner. So if you don't know the basis and you're trying to remember them or memorize them, you will get yourself confused. It also helps to develop a common language to describe various injury patterns, and certainly in the acetabulum and the pelvis in general, there are many variations, but they all follow certain patterns, and that is the pattern that we should recognize by the classification process. Okay, now you also have to compare the anatomical and radiographic landmarks, and that's how we learn. By looking at the model or the cadaver and then relating it to certain radiographic landmarks, and then you understand which fragment is related to which fragment and how to put them together eventually in surgery. It also helps to plan a strategy. If you understand each of the fracture patterns and learn how to approach them as well as how to manage the surgical tactic, then you will have less complications than to go in blind. Let me go through a little bit about the evolution. There's been many classification systems over the years. It started in France, reported by Dauchot and Trochet in the French Society of Orthopedic Surgery, and they describe basically a posterior dislocation with an acetabular fracture. They also describe something called a stove-in acetabulum, which we know as a stove-in pelvis. We know that it's a central fracture dislocation of the femoral head. Later on, two Belgians talked about primary and accessory fractures. So they started to subdivide different patterns by recognition. And they also described the first description of a transacetabular pattern, which will evolve later in different classifications. But these did not stay whole because they were all based on simple X-rays. It was not until 1974 that Judet and Letournel published first their paper and eventually the first edition of this book. And it was based on 630 acetabular fractures, of which almost all of them were operated. And this is a huge number that went from 1956 to 1970. So they were very early in their development and understanding of the fractures. And this was actually based on the fact that they used oblique X-rays. Before Judet and Letournel, they were trying to understand the fracture, and they developed the Judet views. And it was from the Judet views that they understood which fractures belong to which part of the anatomy. And it was a mechanistic classification depending on the mechanism of injury. And it was divided first into the first 5 basic patterns. And they also recognized another 5 combined patterns. So there are 10 categories, and I will go through one by one. It's remarkable that they did not have the benefit of CT scans at that time when they developed the classification. So they're all done by X-rays and the study of the cadaver. If you remember this diagram from last week, the pelvis, the acetabulum is divided into the anterior column, the posterior column, and then the one in pink, and then the sacroiliac buttress, and then you have the two walls, anterior and posterior. So they just 5 components will make up these 5 elementary types. First elementary type, they're always on the posterior wall, starting with the posterior wall. That means the lip of the acetabulum, usually associated with dislocation. Then if you have a larger force, a more medially directed force, then you have the posterior column. So these are the first 2, followed by the anterior wall and of course the anterior column. So that makes it quite simple. Start with posterior, then the anterior wall and column. Then the 5th of the elementary type is a transverse pattern. So this is the pattern that traverses both the elementary and the associated types. So a transverse pattern involves both columns, but it is transverse in nature. Then you come to the 5 associated types, starting with the transverse T shape. So the transverse has extended by a vertical limb into the obturator foramen. So this is separate by itself, called the T shape. Then you have the combined, that means a column and a wall, posterior first. Then the anterior transverse with the anterior or posterior wall. Then you have the anterior column and posterior hemi-transverse, which is essentially an anterior column with a T going into the back of the posterior column. So you form a reverse T as opposed to the T shape. And finally, the 5th one of Judet and Letournel is the associated both column, where the fracture divides the ischial buttress, the anterior column, and the posterior column. So there's that in which no part of the acetabulum is directly connected to the SI joint. So in this case, one of our cases reproduces this very well. And it's with the CT scan that you can identify and correlate much better, because we're able to see it by removing the femoral head, which is sometimes difficult in the plain X-ray. Then in the late 1990s, Martin Thal, David Halford, and James Kellum from New York and Canada and South Carolina, they devised the classification we now adopted by the ASIF group. It was modified from Letournel and Judet's classification and closely follows them in some descriptions, but it was added the direction of injury, the degree of displacement of the fragments, the degree of severity, that means the comminution generally, and it was comprehensive in the sense of A being the simplest and C being the most complex. So this followed the AO classification for most of the fractures of the skeleton. And it also unifies the pelvic ring, which is numbered 61, and acetabulum at 62. So you can actually combine this in the pelvic ring fracture and the acetabulum by describing 2 different classifications. And now it's adopted by CCOT and OPA. And if you try to look at the complexity of this, which can give you something like 2,000 or 3,000 varieties by classification, the best is to use a 3D CT to provide the highest inter-observer concordance if you are trying to describe a classification, fracture pattern by classification. So we go through the AO-OPA classification 6.2 for acetabulum. Basically, there are 3 types of acetabular segment disruptions. The first one is a column. So partial articular of 1 column, that means we are talking about part of the the pelvic acetabulum. Then you have the transverse, that is also partial articular because the other half is still intact. And then you have the type C, which is the bicolumnar or both column fractures, which is called the complete articular. So this is in conjunction with the general classification for articular fractures in the AO. Let's go through one by one, starting with the type A. Type A partial articular, which is the 1 column, always starts with the posterior. So the posterior can be a wall. So this is the first classification of Judet and Letournel. Then you have the different type. So if you have a wall fracture, which is only in 1 piece, it's a A1.1. If you have comminution like a 2 parts, you have A1.2, and you have a marginal infection in addition in the fracture of the acetabulum, you will call it a A1.3. Then you have the A2s, and A2 is the column, again the second classification of Judea and the Tournelle. So you have the posterior column, A2. A2.1 is ischium. That means the fracture actually does not go into the foramen, obturator foramen. It goes into the ischium, and it's considered to be a large, extremely large wall fracture. So it's a type A2.1. If they go through the foramen and into the pelvic ramus, which is the most common pattern, is a A2.2. And if it has an additional wall fracture with the column, then it's a A2.3. Then we go to the A3s. So in A3s, we are talking about the fracture of the anterior wall. It's a A3.1. So fracture just the wall without the column. It's a A3.1. If you have a fracture that goes through the column high, then it's right up to the eyelet crest, it's a A3.2. And then when it's very low, it's A3.3. So this denotes the difficulty and the complexity of the injury, and also the ease or difficulty in the internal fixation method and approaches. Then we go into the transverse orientated, which is the V-type fracture. So in transverse fractures, you have the obturator. When the obturator foramen is intact, then it's called a transverse fracture. So there's as you see here, it is classified by the type 1.1 as infratectal, I mean bisecting the cotyloid fossa here. B1.2, which is juxtatectal, means just short of the dome. And then you have the transtectal, which goes across the articulate surface of this horseshoe, which is a B1.3. When you get a fracture through the foramen, it's called the T-type, and they follow the same types of 2.1 being infratectal, 2.2 being juxtatectal, and B2.3 being transtectal. So that involves more of the articulate surface. Then the third part is the removal of now is a different one, is the anterior column with a posterior hemitransverse. This is a variation of the anterior column alone. You have a horizontal, or rather in this case, actually a vertical fracture through the posterior column. So it's called the ACPHT. Its classification is slightly different from the transtectal, and what you get is B3.1 will be involving high fracture going through here. B3.2 is a low column fracture, and B3.3 is the one that has associated anterior wall fracture. Then we come to the C-type fractures, which is the complete articular or both column fractures or bicolumnar fractures. So you have the first type, which is the high eyelet, C1, right? The fracture goes through from the crista ili on the crest, reaches down to the sciatic notch, but does not join with the acetabulum. Then the posterior column is separated from the sciatic buttress, and the anterior column is separated from the sciatic buttress. And the types are, if you have the same just 3 fragments, it's a C1.1. If you have 3 parts with a fracture through the anterior column, C1.2, and you have the anterior and posterior column, then there are like 5 parts, then it's C1.3. But the primary pattern is a high column, high eyelet fracture. If you have a low fracture, that means fractures that end up in the sciatic notch, then you will have a same pattern but a different classification. So C2.1 will be 3-part the fracture, as you see, without the anterior column fracture. If you have C2.2, you'll see the anterior column fracture, and C2.3, you have both the anterior column and the posterior column. Finally, the most complex one, which is the 1AC3 fractures in which the SI joint is involved, and they are totally different. And again, you have high and low, and this is a bit more complicated with regards to the fractures of this type. So I hope that maybe if you don't understand it in the first lecture, you can go back to the video and just go through slowly, and you will work out the rationale for the classification process, and it will not be such a mystery. So in summary, to successfully manage and treat your patients with acetabular fractures, you need to have a comprehensive evaluation of the hip. So don't forget that there are sub-classifications and supplementary sub-classifications such as avascular necrosis, the presence of osteoarthritis. So it goes into very complex sub-classifications or subtypes. And also whether the fracture is dislocated or the head is dislocated or associated with head fractures. You have to provide the emergency management, which is to try to preserve the femoral head by reduction techniques, for example, and then obtain good radiographic and CT information, which nowadays is easy. Then derive your fracture classification. And because of you know what fracture classification, you can go read the textbook or watch the video how to approach these for specific fracture types. Then you must evaluate outcomes. If you don't evaluate outcomes, you will not know your personal results or your hospital's results. So, and when you report in studies, you have to report with the standard fracture classification, as I tried to show you. Thank you very much.
Okay, great. Thanks, Hodgson. I think that was excellent. I think your elaboration, especially of the AO-OTA classification, I think you really made it really simple and easy to understand. So that was great. So I think any questions, we'll be happy to take any questions.
Yes, sir, Dr. Gautam has asked, is it based on CT classification or X-ray based, which is AO classification?
In today's practice, it will be both. If you have an X-ray based classification, you just go to Letonel's book, you will probably find a variation in his book, because there's also many of them, plain X-rays. But I would suggest that the best way to learn the subclassification and to sort of identify the pattern is to do the CT scan. And if you do the CT scan, 2D CT seems to give people a lot of confusion. You cannot come to a good concordance of agreement as to what classification from 2D. That means you're doing the multiplanar X-ray. But the 3D gives you a very high concordance rate of about 0.8 kappa value. So that will give you a much better picture, and you can rotate the 3D pelvis to see how it fits into the classification. So I would say CT gives you a better result, and the 3D CT will give you the best assistance when you want to learn the fracture pattern.
Yeah, absolutely. And I think if you looked at the Letonel classification, it was originally based on X-rays. Okay, but as we have CTs, that gets, by the time the AO-OTA classification was detailed, they also had CTs. So it was a combination of X-rays and CTs, and they look at both before classifying the fracture.
So this question is quite important, because I'm also getting confused sometimes to differentiate between anterior column, posterior hemitransverse, and T-type. Actually, it is anterior with posterior hemitransverse, because in Letonel and Jude has written that anterior column or anterior wall, I think, in his classification.
Maybe it'd be good if I just show you that slide again.
Yeah.
Yeah, because then you can get.
Yeah, I can understand it.
Yeah, so you can see it better. Let me go back to this slide of the B3 and B. Okay, let's look at this. So if you have a transverse pattern, the obturator foramen is intact. If you have a T-type, the obturator foramen is split. In fact, there are other sub-T types, a high T-type, anterior T-type, middle, and the posterior T-type. But in the anterior column hemitransverse, you notice that the fracture pattern starts from the ASIS. In the transverse pattern, the fracture is below the AIIS. So if you see an ASIS or iliac crest fracture up here, it cannot be a T-type fracture. So this is the anterior column, like this, with a hemi-transverse, which is posterior. Okay, if you have an anterior one, it's actually an anterior column with a wall, which is actually a A3.3, not a B3. Okay, does that answer your question? Just look at the fracture exiting upwards. All the transverse fractures never exit outside the sciatic notch and the ASIS line, AIIS line, anterior inferior iliac spine. But the anterior column posterior hemi-transverse always exits above the AIIS or even
Yeah, absolutely. And there are other two things that you need to look at is which way is the head following. So if you anterior column hemi-transverse, the head is usually displacing with the anterior part of the fracture, okay? So that's the other thing to look at. And also the anterior fracture in an anterior hemi-transverse, anterior column hemi-transverse tends to be more comminuted than the posterior one, while it's the other way around in the T-type fracture. So these are the few things that you need to look at, but the fracture line, as you can see, is slightly different in the anterior column because and posterior hemi-transverse because the anterior column is involved. Now, sometimes the both column fracture can also be mistaken between that and T-type and anterior hemi-transverse. And so you need to really look at these very carefully.
Yes, especially the low type. So this low type, if you don't have good CTs, you might miss this and you think that it's a T-type. But again, the fractures always exit out there. So this looks a little bit like an anterior column, posterior hemi-transverse, except there is a superior acetabular fragment that is separated from the ischial buttress. So this sort of low iliac with the transverse will look very much like a anterior column, posterior hemi-transverse.
Yeah, and also I think this is important, and this confusion seems to be there in a lot of people, is that Latunal described the associated both column fractures. It doesn't mean that's the only, just because both columns are involved, it becomes an associated both column fractures. The associated both column fractures means that the dome of the acetabulum is actually separated from the SI joint, which is the axial skeleton. Okay, so that's the important thing to differentiate the both column fractures from the other fractures, okay? So just because both columns are involved in transverse fractures, in T-type fractures, in anterior column, posterior hemi-transverse, in transverse with posterior wall, and associated both column fractures. But associated both column fractures, the dome is separated from, so there's a fracture line going between the dome, exiting either anteriorly or more superiorly, or even at the SI joint, which separates the dome from the SI joint and the axial skeleton.
So one more common confusion is about the high superior ramus fracture, which we get confused with anterior wall fracture, sir. So how to avoid that? What to look for anterior wall fracture?
Anterior wall fracture.
Yeah,
anterior,
because we.
Yes. What was the question about anterior wall and an anterior column? Is it?
Sir, the high superior ramus fracture, how to differentiate it with anterior wall fracture?
Well, anterior wall fracture is a separate piece. It's a totally floating piece. The ramus is not connected to the ramus at all. So the ramus may be involved. That means the anterior iliopectineal line can be broken in two places. Iliopectineal line, if you look on the plain X-ray or in the outlet oblique view, obturator oblique view, you can see the fracture is separated into two places. So that will, the middle part, the middle fragment will be the anterior wall fracture.
I think the moment the joint is involved, it becomes an acetabular fracture. Okay, so if the so I think you may have a fracture very close to the joint of the superior pelvic ramus. Okay, but If the wall is fractured, it will be a separate fracture of the wall from the ramus, okay?
It's best to see it on a CT, 3D
Yeah.
CT, with the head removed. You will see,
Yeah.
because there is a subtype of Goulet. He calls the lateral part of the superior pelvic ramus as the root of the ramus. So there are fractures there that can confuse people.
Yeah.
So one more question which you have explained in previous talk is that when we have to do CT scan, why it is so important when to do geodet view also with the CT scan. I think you have explained it last time, sir, but
Yeah.
Yeah.
again,
Okay, Judet views is an X-ray. Okay, it's an X-ray which you can correlate with, for example, fluoroscopy when you're doing surgery. If you don't have any X-rays and you only have very nice CT scans, you only look at it in 3D, you do not see it in the translucent you get from a fluoroscopy. So it helps the surgeon to identify the same pattern intraoperatively when he does his fluoroscopic picture, to look at a fragment, and he looks at the Judet views. But of course, if you're planning the surgery, say on a plastic bone or synthetic bone, syn bone, then you can do the 3D CT to draw your fracture pattern. So both are supplementary to each other.
so when you have showing the subtypes of transverse fracture, it is from infratectal, then it is going above. And when you are showing it with posterior hemitransverse interior column, first it is high type, then low type. Why it is so? Because it's difficult to remember, like from low to up, if we can go, that is in one way, and in other one, why it is first is higher one, then the lower one.
Okay, the T type or a transverse type, the pattern is 90 degrees to the anterior column posterior hemitransverse. The T rotates. So this is the T or transverse type. This is the anterior column posterior hemitransverse type. So they should not be confused. It's just a 90 degrees to each other. That's the best way I can tell you how to identify.
That's great, sir. So I think, sir, we can have one lecture by John, sir. Then we will ask the rest of the questions in the last.
Sure.
Good.
We're going to now come to the decision making in acetabular fractures, and go back to Marvin Tile's statement about pelvic fractures bleeding to their death, while acetabular fractures limp to their death. And here's a classical example. Here's a patient who was seen elsewhere initially, and these were the initial X-rays. This was the only X-ray taken. And I'm not sure whether any fracture was diagnosed, but even in retrospect, it's a little difficult to make out anything. These were his X-rays 3 weeks later. This is him 2 months later. And by 6 months, this was the condition of his hip. Okay, now this could have been a simple fracture to treat if it had been diagnosed earlier, but this eventually ended up in an end-stage arthritis situation where a total hip replacement was the only option. Okay, so I think we need to look at which fractures we can treat non-operatively, the indications for surgery, what are the contraindications, and are there indications for acute THR? Of course, when you have secondary osteoarthritis, then a THR is often the only option. I think to understand this, you first need to have a diagnosis. So unless you do your investigations properly, you will not be able to get a diagnosis. So the management of any fracture needs logical decision-making based on clinical and radiological assessment of the injury. So you must have a high suspicion of injury for these fractures. You need to understand the personality of the injury and then decide on your appropriate treatment. So here's another patient, okay? So that was not an isolated case. I think we've seen about, I'm not saying we see this every day, but almost every year or second year, we see one patient like that who has been totally missed in terms of the seriousness of his injury and then has ended up with osteoarthritis. So here's another patient. This was his original X-ray in 13, and he presented to us in 2016, and this is what his hip has become. Okay, and again, the CT scan showing you that this is really related to this acetabular fracture. You can see now the secondary osteoarthritis. The other hip is perfectly normal. So I think you have to be able to do the appropriate investigations to diagnose the fracture. So this is another patient. This was treated by us. This is a young lady. Again, if you look at the AP X-ray, it's really hard to make out a definite fracture. But if you're suspecting the fracture, if you examine the patient, find that there's pain on movement of the hip, you can't see a neck fracture, look carefully for an acetabular fracture. And there, if you do the Judet views, you can see how the posterior column is fractured here. There's a definite column fracture involving the posterior column here. Okay, fracture involving the posterior column. And because we had diagnosed it, we could go ahead and fix it. And she went on to do well. So I think these, some of these injuries which look very trivial on the initial X-ray, especially the AP X-ray, it could be a more significant injury, and you will miss them if you do not appropriately investigate them. Okay, so I think you need to look at patient factors, so the surgeon or the fracture pattern, the expertise of the treating team, the healthcare team, in other words, the surgeon, and the kind of infrastructure and he's working in to be able to come to your proper decision. So the patient factors include things like age, comorbidities, associated injuries, and also compliance. So I think you have to look at these. Sometimes a very elderly patient, the risk of any major surgery may be not justified, and you may have to treat them conservatively. Okay, you need to look at the fracture pattern, and this is obviously the displacement. Is this hip stable or unstable? And we're going to go through these factors as we go along. Is the femoral head congruous with the acetabulum? This is really important. What is the degree of comminution of the fracture? Is there a femoral head fracture? I think that will makes it much higher risk of developing problems, and those are situations where sometimes you may decide on a primary arthroplasty. And of course, you need to look at whether the fracture is it a fracture that you can fix reasonably to be able to mobilize the patient. And of course, your training, your expertise, your team, and the infrastructure that you're working in are again important, because these can sometimes be quite major surgeries which can take 3 to 4 hours or even longer. And if you don't have a good anesthetic team and a good infrastructure, then you would be risking the patient's life if you're taking on these difficult and often long surgeries with considerable blood loss. Okay, now, what are the indications for non-operative treatment? I think if you have a stable hip that is congruous, the fracture is completely undisplaced, or minimally displaced fractures. And here I think if you look at the low anterior column and the low transverse fractures, these are fractures where the weight-bearing area of the acetabulum is not significantly involved. And these are the ones where most likely you may be able to treat conservatively. And there's a concept of secondary congruence with both column fractures, which we'll discuss, where you may treat conservatively. Okay, so there have to be certain criteria which allow you to treat these non-operatively with reasonable results. And one is if the superior acetabulum is intact, the femoral head is congruent with the acetabulum on both the AP as well as iliac and obturator oblique views. So it's important to get all these views, and also do these views out of traction. If you do this with traction, sometimes you may get misled. Okay, and there should be no evidence of posterior instability. Okay, so there's also this concept of the roof arc angle or Marta's angle, where if you draw a line from the center of head vertically up and then to the fracture line, this angle, according to Marta, should be 45 degrees in all three views. That means in the AP, in the obturator, and in the iliac view. And if these are above 45 degrees, then Mata suggested that these could be treated conservatively because a significant part of the weight-bearing dome was still intact. However, this has been modified a little bit recently by Vrahas, and who actually said that these angles are not as important in all the three views. So I think if you look at the AP view, 45 degrees is good. If you look at the anterior part of the acetabulum, that is the obturator view, even maybe 25 degrees of an arc may be enough. While in the posterior part of the acetabulum, in the iliac view, this angle should be as high as 70 degrees, because that is the major weight-bearing area. So the Mata's angles or the roof arc angles have been modified by Vrahas et al. In 1999 to represent more accurately the weight-bearing area of the dome of the acetabulum. Now, how do you decide this on the CT scan? I think you need to look at the subchondral arc of bone. So because, as you know, the CT scans go in this direction. So you need to look at how much is 45 degrees. And 45-degree angle, if you look at the view, works out to about 2 centimeters from the roof of the acetabulum. So I think this kind of varies a little bit between 1 and 2 centimeters. So that is if that 2 centimeters of the subchondral arc is intact, then you know that the weight-bearing area of the dome is intact. Then Tonetta talked about the dynamic stress views to look at stability of the hip. So this involved an examination under anesthesia and putting the hip through a range of motion in flexion. Okay, so and this under fluoroscopic guidance. So if you saw any subluxation or incongruence in the joint, consider open reduction and internal fixation. Of course, if the joint actually dislocates or subluxes while you're examining it, then you would need to consider open reduction and internal fixation. So this is an interesting case. This patient had bilateral femoral acetabular fractures. You can see that on the right side, where it's quite a small posterior wall fracture. The left side is a little bigger, but the hip on the X-rays looked congruent. CT showed that a reasonable part of the posterior wall was involved. But when you examine this patient under anesthesia, you can see as you flex the hip just subluxes posteriorly. So you know that this is an unstable situation and would require surgery. And interestingly, when we did operate on this patient, there was this fat pad which was really stuck between this posterior wall fragment and the acetabulum. So we had to actually get this fat sort of chunk of fat out from underneath the posterior wall fragment to be able to reduce. It was also comminuted, so we used a combination of a lag screw for the wall where in the bigger fragment and this spring plate, as we call it, where we bend a 1/3 tubular plate after cutting it through one of the holes so that it kind of buttresses the acetabulum. And that's the lag screw, the spring plate, and then the buttress plate on the back being put in. And this patient went on to do well. These are his other x-rays showing that the joint is well fixed and there's no intra-articular hardware in the fixation. Okay, now what is secondary congruence? In Mata and Olson, criteria cannot be applied to bicolumnar fracture because the dome is separated from the from the axial skeleton. So usually these fractures will need open reduction and internal fixation. But because these fragments are kind of separated from each other, unlike the T fracture where there's still some contact with the dome and it's difficult to get any kind of secondary congruence, you have to get a good accurate internal reduction with internal fixation. Here sometimes the fragments with traction can kind of come around the head in a reasonably congruent manner. The hip will be a little medialized, but there'll be a relative congruency between the fragments and the femoral head. So if a patient is a high risk for surgery, sometimes it may be appropriate to treat them non-operatively. And because of the secondary congruence, they will get a reasonably good result. So here's a patient. You can see that here this dome fragment is separate from the axial skeleton. There's a fracture exiting here. This is the sort of spur sign. It's not very clear on this view because of the gas shadows, but you can see that is the intact part of the iliac bone there. Here's the fracture line going through here, going out here. And this patient had some surgical risk, so we decided to treat him conservatively. Again, you can see how on the CT the fragments are falling together around the head. And this is how he did on traction, went on to have a fairly congruent joint. And in follow-up, you can see that he's got a fairly congruent joint and was able to function quite well without problems. Now, we've talked about conservative treatment. What are your indications for surgery? I think if there's more than 5 millimeters of displacement, especially in the weight-bearing arc, okay? If there's any loss of congruence in any of the three views of the joint, of course, posterior wall fractures with instability, we touched on that. If there's an incarcerated fragment within a joint, especially a large fragment, or dome impaction or impaction, then you need to think of surgery. More relative indications would be displacement between 2 to 4 millimeters. If there's a marginal impaction of more than 5 millimeters, if more than 40% of the posterior wall is involved, even if the hip is clinically stable, I think it is considered as an indication for surgery. Polytrauma patients where you need to mobilize them, so maybe even in less displaced fracture, you would consider surgery. Once the patient is stable, remember that. And associated femoral head fractures. So here's what we mean by marginal impaction, where a part of the articular cartilage of the acetabulum is actually pushed in. So even though the wall fragment may look reduced, if that impaction is significant, it will lead to incongruence in the joint and eventually lead to secondary osteoarthritis. Okay, so if you have any fracture which is going through the superior weight-bearing dome or roof, if there are transverse fractures which are transtectal or just juxtatectal, so that means high fractures, both column fractures, retained bone fragments, and if there's a femoral head fracture, these are definitely operative indications. So here's a transverse with posterior wall fracture with combination. It will definitely be an indication for surgery. Retained fragments. This is a young patient who had a dislocated hip, which was then reduced. But if you look at the joint, it is not congruent. Okay, you can see that. You can see the fracture line is going across. Both columns are involved, although it's not a bicolumnar fracture. It's a transverse with a posterior wall fracture. And you can see this large piece in the joint, which was making the hip joint incongruent. Okay, so this is getting in the way of a proper reduction, and you need to get this fragment out, reduce it, and fix it. Here we used a safe surgical dislocation approach and got the fragment out, fixed it, and then again lag screws and a buttress plate at the end of it. Now, what about this patient? So here you can see this kind of severe combination which is in the posterior wall, but you can also see incongruence and impaction. Okay, there's a retained foreign body, there's impaction, and there is a loose one. So these are absolute indications for surgery. Femoral head fractures in combination with acetabular fractures again would be an indication for surgery. I think depending on the age of the patient, you would think of doing a fixation or an arthroplasty. Now, sometimes usually these open reduction and internal fixation are not emergencies. You would reduce a dislocation, wait, get all your investigations done, and then do the surgery at an appropriate time when the patient is stable and you have the correct team there to help you with the surgery. So it will not be a middle of the night surgery, but if the joint is irreducible, that means it's a posterior dislocation and you're unable to reduce it close even under anesthesia, then you may have to opt for urgent surgery. If the hip is totally unstable, Of course, if there's associated vascular injuries and open fractures, these are indications for emergency surgery. Okay, now this was a patient who, in spite of trying to reduce the hip, it was irreducible. And you can see there's also a head fracture there. And so you need to reduce this and get this fixed as soon as possible. Now, just a word on total hip arthroplasty. I think this may be considered as a primary or secondary procedure. I think as a secondary procedure where there's secondary osteoarthritis or AVM, I think there's not much controversy. With acute total hip, there's still some controversy. There initially it became a sort of trend many years ago. Then gradually the results of primary total arthroplasty were not so great. But today with advent of better techniques and better implants, there will be certain fractures which may be better managed with total hip replacement. And here's an example. This lady actually came to us a little late, about 3.5 weeks after the injury. And you can see by then the head is already pretty badly impacted. It's a very displaced fracture and a bone is not particularly of a good quality. Okay, so here we decided to fix the posterior column, use impaction grafting using the femoral head, do a cemented cup. So there you can see the plate fixing the posterior column, the cup, and then total hip replacement. Here again, we use the Exeter stem. And you can see how this hip is now reduced and doing well. And interestingly, she went back after this and didn't come back for follow-up, but came back about 2.5, 3 years later, where she had actually had a distal femur fracture, which was treated elsewhere, and that ran into complications. So she came to us for this fracture treatment, and because she came for that, we could get an X-ray of the hip, and she was doing quite well with the hip. You can see this is slightly high and medialized, but clinically she's doing very well with the total hip replacement. Okay, and if you have a combination of a posterior wall and a head fracture in an older patient, so if the patient is in his 60s or 70s, got a posterior wall fracture and a femoral head fracture, which in a young patient you would decide to fix. But in an older patient, here's where a total hip replacement would be a reasonable solution. This is a case done by Dr. Mahesh Kulkarni from Pune. Okay, so at the end of it, you need to look at the operability of the fracture in terms of osteoporosis, how comminuted it is. You also need to look at the general condition of the patient. Also, whether you are capable of fixing the fracture, and then some fractures probably are beyond good stable fixation in almost anybody's hands. Okay, so I think you need to be able to decide sort of very rationally and sensibly which patients you should be doing yourself and which patients may be better off for that you refer them to somewhere where these fractures are being dealt with on a regular basis. Okay, so you can also have combinations of pelvic and acetabular fractures. This was an elderly, in fact, nun who just came to me initially with this X-ray, and my initial feeling was it was just a pelvic fracture, but then when we got further investigations and a CT scan done, you can see how you have a transverse fracture involving the acetabulum as well as a pelvic fracture there. So here we went in through the ilioinguinal approach, posterior plate and lag screw for the iliac fracture here, and then a plate extending from the brim of the pelvis, along the brim of the pelvis, from close to the SI joint all the way up to the symphysis pubis together. And she did really well. This is her at about 2.5 years post-op, doing quite well. Okay, I think as we mentioned, some of the possible reasons for not operating include the fracture, and you need to look at the personality of the fracture, the age, comorbidities, the osteoporosis, the fracture pattern in terms of the comminution, and your, as I mentioned again earlier, the surgical team and the experience. So all these things have to be taken into account before deciding on your fracture management and your decision to treat operatively or non-operatively. So I think rational decision making is key to success in acetabular fractures. You must have clear indications where you're going to do non-operative or operative treatment. You should also be aware of the contraindications, assess the personality of the fracture, and then you need to have all the facilities, the training, the infrastructure to go ahead and deal with these fractures so that you're able to do a good job on treating the fracture. So I think I'll stop there and we'll go on to any questions that there may be.
So we have a few questions in the chat box, like
Sure.
one from Dr. Rajendra Tripathi from Uttar Pradesh. He wants to know about hairline fracture of acetabulum. Is it best to manage by traction, plaster cast, or anything else?
Well, plaster cast is not a management for acetabular fractures, especially in the adult. I mean, there may be some young kids where you might be able to do that, but I think traction is an option in very minimally displaced fractures. But what's important is you do all the views to make sure that the weight-bearing area is not involved or there's no displacement in the weight-bearing area. And then you can treat conservatively. Yes, there's a way of treating. I mean, there was a time when a lot of these were being managed conservatively on traction, but it means keeping them on skeletal traction usually, whether in the displaced fractures, or sometimes as long as 2 months before the fractures actually heal up enough for you to leave the traction. So you need to think about that. Okay. So I think, Coxon, any comments on that?
Yes, I think we as in all joint fractures, you look at a step defect or a gap. So that means if you want to decide on a non-operative treatment, you must accept a certain step and gap, which must be seen on CT scan. You can't just do plain X-rays and say, look for 1 millimeter, 2 millimeter. So you have to do your CT scans in 3 planes, and then you look at the 2D CTs and decide whether there's a step. Usually we take 1 to 3 millimeter as being so-called acceptable. Less than 1, you certainly don't need anything. More than 3, you would have to do a surgery, because unless you can put traction and prove that the reduction happens during traction, then you need to repeat the CT scan. The second one will be the gap. So if the acetabulum is split on the dome, usually we talk about 3 to 4 millimeters again. So if you have a larger than 3 to 4 millimeter, the head you will get resorption around the edges, and that may increase to 5 or 6 millimeter by the time the fracture stabilizes into a secondary congruent. So the head will then be pushing up against the gap of that. So you need to have some parameters which studied by CT scan.
And then you have to also follow it up very closely, because these very often something that looks undisplaced initially or even on traction, a week later it would have displaced. So because maintaining traction efficiently is another issue nowadays, because you can't, earlier you could keep the patient in hospital for 6 weeks and things like that. You can't do that today in most places.
Yes, very expensive in Singapore.
Yeah. Even in India now, it's very difficult.
One of the tricks I've used before, as we did in the distal tibia, proximal tibia fractures, if you put a skeletal traction, usually in the distal femur, and you put them on a CPM machine.
Yeah.
So you put it on a CPM machine, so it creates a sort of a secondary congruent while the fractures are still moving. And then after a while, as they get stuck, as they become a bit sticky together, and then you can find that the range of motion actually is pretty good.
Yeah.
So get some motion after the first 4 or 5 days of pain control.
Yeah, and so that's, but mostly you would do that for patients who you don't want to operate for some reason.
Yeah, you don't want to operate, correct.
Another, sorry, I saw that question about
roof arc angle. Is it applicable for all the fractures?
So not for bicolumnar fractures, okay? Again, posterior wall fracture, it's not so.
About the bicolumnar fracture, you have mentioned secondary contact. So he was mentioning about the secondary congruence about the both column fractures. Sir. So where else we can expect secondary congruence other than that? Do we have?
So, I mean, it's where a patient fracture is so minimally displaced that you have some congruence already. But in a displaced fracture, you will not get this in the T-type fracture, etc. Okay, because the dome fragment is not free. Okay, so you will not get a secondary congruence. You will only get it in a both column fracture because all the fragments are free of each other. Okay.
In the bicolumnar fractures or both column fractures, the dome, the anterior column and the posterior column may come together, but they may be separated from the ischial buttress. So these come together, they can do this, but you don't need to join to this. So the dome that holds the head is actually secondary congruence, is like the anterior column and the posterior column coming together.
Then they go a bit medial and then.
Yeah, it's almost like a floating head away from the ischial buttress.
Yeah.
That's why it's important to be able to classify that, but it doesn't happen in anterior column, posterior hemitransverse. That the posterior hemitransverse is still connected partly to the SI joint. So if you don't get congruence and hard to get congruence, you have to operate on them.
And so about the impaction, when you talk about if the part of the impacted part is small, then what is the prognosis wise, or if it is large? And when you ideally operate on it, when it is smaller, means small, or when it is large? And about the age also, so if you can consider.
Sorry, I didn't get that question.
I think the question was about marginal impaction. Is the size make a matter, or would you operate if it's a smaller size? Would you operate if it's a larger size or marginal impaction, or would you operate in all marginal impactions?
So I think if there's a significant, so what does marginal impaction mean? That means a part of the cartilage has got pushed in. So you need to look at the step. And if that step is significant, I think probably anything more than 2 or 3 millimeters, I think you need to do something. Yeah.
Okay, sir. So
in many cases, I look at a wall. If the wall is large, there's a small marginal impaction. The wall can act as a circumferential buttress. If the wall is small, and even if you have a small marginal impaction, chances are the head is going to impact into the marginal impaction. There's nothing to hold it. Then you tend to have a poorer output.
Yeah. And you need to elevate it. And sometimes you can get a very small screw into it if you have a reasonable amount of subchondral bone. Otherwise, you take in some graft and pack it or bone substitute and pack it behind it.
Yeah.
And the wall fragment will go over it and hold it there.
Yeah, it's like putting a blocking screw or a rough screw.
Yeah, yeah.
And so when you consider posterior wall fracture for conservative treatment, means how much, like about the size, in few paper it is written as 20% and 40%, or when it is about the age, what?
So I think two things: if stability. Okay, so even if it is less than 25%, but it is causing some instability, you need to do something. If it is more than 40%, then you have to do something. If it's somewhere in between, then you look for stability and then decide.
Don't forget, only look at the bone. There's the posterior capsule.
Capsule and the labrum also.
Labrum, capsule, which if they are avulsed, you won't see it on the CT or X-ray. So the dynamic test, Barlow test, and the test of instability is important. And so the video that you showed was perfect. You have to do that when you want to examine. Many of these patients are already dislocated. So when you do the reduction, do the press again to see whether it falls out. If it falls out, it doesn't really matter how big the fragment is, because it can be diminuted and small, and still with capsular tear or labral tear, you will still be unstable. So you still have to reduce them and hold them.
And also you need to look at the congruency of the reduction. Okay, sometimes the hip would feel as if it's been reduced, but you need to really look carefully at the x-rays to see that you have a completely congruent joint. Okay.
So, sir,
The other thing, one more point is that after you reduce it, if it's not congruent, you repeat your CT scan because you could have put a fragment of the rim in the joint, and it was out until you give it a pull and it fell into the joint and got incarcerated.
Absolutely, I've seen that a few times.
So it is actually decided after the fluoroscopy in OT, sir. Right, sir?
No, I mean
dynamic.
Where you are trying to decide whether you need to do surgery or not. Where you're decided to do surgery, then it doesn't matter, huh? Okay, but where you are trying to decide whether you need to do surgery or not, so you think you may manage with conservative treatment, it's important to do a stability examination. So ideally, when you reduce the fracture, that's the best time to do it. Okay. So when you reduce the fracture, that's the best time to test it. So if you do it under anesthesia, if you're doing it on the OPD without anesthesia, where it is done in some places for whatever reasons, maybe logistic, etc., then you need to check that, especially if the fragment is somewhere between 20 to 30%. You want to know if it's stable or not, you need to do a EUA and fluoroscopic examination to look for it.
So one question about the primary THR was asked. So when you decide between the osteosynthesis and the primary THR, or do you prefer it the reconstruction first, like osteosynthesis first, and even if in the elderly, if required, then later we can go for THR?
So I think this is still a slightly controversial area. So most situations, we would first plan to reconstruct and then do a THR later. But there are some patients where you know that it's going to fail. Okay, like for the case I showed you, or you have a wall head fracture as well as a wall fracture. I think you know that you're not going to get a good result. So there, if you have the facilities, again, so this becomes a major surgery. So you need to be not doing it in a proper center with someone who's experienced in this kind of surgery to be doing it. Okay. So I think now there is but you also need to fix the acetabular. It's not that you just do a THR on the fracture. Okay. You need to fix the fracture, at least stabilize it adequately so that the acetabulum will hold the THR. Okay. If you're going to just do it on it. So earlier on, people were doing a primary THR without actually fixing the acetabular fracture. And those results were terrible. Okay.
If you use a THR, does it matter if you use cemented cup on a partially fixed fracture, or would you always use uncemented with screws?
Usually uncemented, but in that particular case, we used impaction grafting because she had quite osteoporotic bone, and because we were not fixing both columns, I was little, and but we got the main posterior part well reduced. It was only part of the anterior column that was still there. So we used the head, did impaction grafting, and then cemented on top of that. But yes, by and large, it's usually a multi-hole, multi-lock type of cup, which has multiple holes to give you peripheral hold as well. But you have to have good quality bone then. If you don't have good quality bone, then an uncemented cup is going to be also unsuccessful.
And sir, after how many days you prefer to do osteosynthesis? Like even during the COVID situation, it is not possible sometimes if it is the patient is positive. So what is the maximum limit, and ideal is after how many days we can go for?
Well, I think for the posterior approach, there's no problem about doing it as soon as you've got things in. So you're not going to do it in the middle of the night, just like the next day or the next list that you have, where you have all the correct team to do it. If you're doing a ilioinguinal approach, earlier on there was a thing to wait 5 to 6 days at least, because Bleeding tends to be a lot more if you operate on the first few days. That's something which you need to look at very carefully in terms of patient stability, etc. So we don't always wait for a week or something. We would do it if the patient is fairly stable, etc. We go ahead and do it.
Great. It's not so urgent, and because many of the acetabular fractures, they are not in, they're not in shock.
Yeah.
So they're generally quite well. So you can choose your time, and usually there's not much to correct before you need to go in.
Yeah. So you want to get them mobilized soon. The only thing if you know you have to do an ilioinguinal approach, there was a hesitation to operate in the first 2-3 days because you thought there was going to be much more bleeding. There is definitely some more bleeding, but I think today
Not a lot more.
Yeah, not a lot more bleeding. So we go ahead and do it.
And so in case of the poor soft tissue, do you change the approach or like that mini approach, or do you wait for some time to?
Yeah, I think that's one area which we didn't touch on is Morel-Lavelli lesions. Okay, so more often with pelvic fractures, but even with acetabular fractures, sometimes you can have a significant Morel-Lavelli lesion. And if you're going to operate through that, you're going to risk infection. Okay, so I think that's a situation where you would have to deal with it. Someone asked about open fractures. When an open fracture, your treatment would be to debride and then go ahead and do the fixation as soon as the wound is okay. In a Morel-Lavelli lesion, sometimes you may have to deal with the Morel-Lavelli lesions, and there maybe sometimes go for, especially if the fracture is not very displaced, you can go for minimally invasive fixation techniques. Anything?
The Morel-Lavelli usually on the buttock side. So for posterior approach,
yeah.
But you can learn how to do them through the ilioinguinal or stopper approach.
Yeah.
But you try not to do posterior approach, and certainly not the iliofemoral approach in Morel-Lavelli.
Yeah.
Avoid that like the devil.
Yeah, that is bad even in best of times. So if you have Lavelli lesions, you're going to totally devascularize. So I think this is something you have to watch out for, because I know one case I remember very clearly where we didn't suspect it pre-operatively. And once we made our incision, we had this huge sort of drainage and that was already kind of looking infected. And that patient ended up with a post-operative infection, I remember. So I think you need to assess them very carefully before you take them for surgery for these fractures.
Because in few of the WhatsApp group, what we used to see that it is discussed on the basis of X-ray only, and usually the soft tissue part is not covered. So how you think about that?
All fractures are soft tissue injuries, okay?
The broken bone inside.
Yeah. So I think that's very important. Okay.
Okay. Yeah, just one question, sir, about the postgraduate. What fracture is more common in elderly people, according to your experience, and what is more common in adults, so that even they get the X-ray during the examination, it's easier for them to identify.
In what amongst acetabular fractures?
Common, yeah, among acetabular fractures. Yes. Common fracture in elderly, what you used to get, sir, more commonly?
Usually anterior wall or anterior column, because they fall on the side. Transverse fractures are not uncommon. Fracture dislocations posteriorly are unusual unless they are in a motor vehicle accident. So you're talking about people with trivial falls. So transverse, anterior column, anterior wall.
Yeah. So you see more of these in the elderly than you see in the young, which is usually either a major multiple injuries situation or posterior dislocation with a posterior wall fracture or posterior wall and transverse or posterior column fracture. But these transverse anterior column, anterior wall fractures on its own is much more common in the elderly in osteoporotic bone.
And just one question about the spring plate, sir. What is it?
Okay, so I think maybe in the posterior wall block, I'll be showing it. So it's basically a 1/3. So there are two types. One is today some companies are making spring plates which are prefabricated. But what we tend to do is just cut a 1/3 tubular plate, usually a 3 or 4 hole, through one of the holes and then bend the spikes a little bit so that they dig into the bone. And then when you tighten the screw, this buttresses the posterior wall fragment. So where there's comminution and you can't put a lag screw satisfactorily, this is the way to do it.
So just what I understood about the column fracture, sir, when it is usually all the column fracture is through the obturator foramen, and for the wall fracture, it is usually needs plate always if we are going for operative treatment. Is it so, sir? Column fracture we are doing with a screw or plate?
Sorry, I didn't get your question.
Sir, about the column fracture, sir, it is always through obturator foramen.
It depends
Anyone,
on
like column or posterior column. Is it
How do
so,
you use it? Some column fractures may be bony. Rather than go through, they can go through the ischium without entering the obturator foramen.
Okay.
Like the the A2.
Classically,
A2.1, they actually fracture is a column fracture, but it does not exit through the foramen in the rami. It goes to the back of the ischium and it breaks off as a single piece, bone to bone all the way. You can put like screws, just like screws would do.
We've even seen transverse or T-type fractures with the vertical limb actually exiting into the ischium rather than into the obturator.
There's a classification for that. Next week's lecture.
Okay. Yes. Okay.
Okay.
Thank you.
I think great. Thanks, Coxon. Great.
Thank you. Okay. See you again next week.
Yeah. Same time.
I will advise all the listeners to go through the video again when you can see that on YouTube and try to practice the classification.
Yeah, I think that was a really nice presentation of the classification. I think that was excellent. Yeah, great.
Thank you so much, sir.
Okay. Good night.
Dr. Mukhopadhyay, there is a message in the chat box for you, if you can check.
Yeah, so I think we'll have to go off live before we can do that, isn't it?
Yes, sir.